Hi, everyone. We're going to give folks a few more moments to join. We are expecting over about 500 or 600 participants today. So we want to give everyone a fair chance to hop in and work through their Zoom email. So we'll give folks a couple of more minutes and we'll start at about 12:03 Eastern time. And also for those new to any webinars from the National Center or the National Crime Victim Bar Association, we love to hear where you're from. So go ahead and post your name and your organization or agency in our chat box. See some new faces, familiar faces. We got folks in Iowa, Michigan. Welcome, everyone. All right, we're going to go ahead and get things started. Thank you for joining the National Center for Victims of Crime and the National Crime Victim Bar Association for this training on sexual assault and abuse and substance abuse treatment centers. My name is Richard Washington, and I will be your moderator for today. Just a few housekeeping items that I would like to note for anyone who may be new to the Zoom platform or just needs a refresher. There is a chat box that a lot of folks are already using that you can use to send messages to the entire group, to myself or our IT coordinator, Cameron, if you're having any issues. At the bottom of your screen, you will also see a Q&A box. Please click on it and type any questions that you may have for the presenter throughout the webinar, and I will ask them to our panelists at the end of the webinar during our Q&A session. It is extremely important that we do follow that one small rule for using the Q&A box, since we are expecting over 500 participants today during this webinar. We want to make sure that we are answering all questions, or that we can follow up in another email following this webinar with questions that we did not have time to answer today. As I stated earlier, we will also be sending around an email with the webinar recording, as well as a link to a feedback survey for you guys to give us a little bit of feedback on Susan's PowerPoint and Susan's presentation today. So we do want to go ahead and get things started, as we only have about 50 minutes or so for Susan's presentation. So without further ado, I want to introduce to everyone Susan Ramsey.
Thank you so much, Richard. And I'm so glad you all could join me today. I'm going to tell you a little bit about myself, and then because I am my favorite topic, but besides all that, just to give you a little background. So I am a former registered nurse. I've been an attorney for 35 years. When I was a registered nurse, I was also a rape crisis counselor in an emergency department in the Northeast. I now live in Florida. So out there behind me is West Palm Beach, Florida, for those who want to know some of the aerial views. I have worked with survivors for a long time. I am also myself in long-term recovery or remission from substance use disorder. In other words, I'm a drug addict and an alcoholic. I now have, in the last decade, been focusing a lot of my practice on, the issues regarding substance abuse treatment facilities. For the most part of my career, I've done a lot of medical malpractice litigation, and I kind of came into this because I did not go to treatment to get sober. I'm not for or against it, but that's not my experience. But my experience has a lot to do with my time in South Florida. And so over time, I have had the privilege of representing survivors in substance abuse treatment facilities who have been sexually assaulted by staff and other issues related to that, as well as other types of claims, wrongful death claims and the like. So I'm also promoting the article that I wrote for Trial Magazine that was published in 2020 that sort of goes through some of the points we're going to talk about today, but maybe has some more practical guidance. I know that there's a vast amount of experience out there that's listening, of folks who have a ton of experience working with survivors in all sorts of different levels, the criminal justice system and the like. This is one of the ways that I find a way to help survivors. I'm also a member of the, it's now called the State's Attorney Addiction Recovery Task Force, which used to be known as the Sober Home Task Force, which was created in 2016 as a result of a lot of bad things happening out there in the world of treatment for substance use disorder. So I'm going to take you right to a little clip from American Greed, one of my favorite shows. Assuming I can get I'm not advancing my screen here. There we go.
In this episode of American Greed, Kitty Chapman catapults from personal trainer to mogul, running a drug treatment business.
He made a massive amount of money. We're talking millions of dollars.
But something isn't right. Chapman seems to have made it far too big, too fast.
When you go from making 5 to 6 figures one year to making 10 million plus the next year, that's an indicator. These are things that we look for when we're doing investigations.
And Chapman's halfway houses, or sober homes, are anything but sober.
Drug use was rampant at the sober homes. We know that Chapman himself directly provided the drugs to keep people high.
And beyond the drugs, Chapman further exploits some of his female clients.
He was able to twist these women into becoming prostitutes for him. He became a pimp.
Kitty Chapman hauls in more than $16 million off the backs of vulnerable clients.
Kenny Chapman saw a chance to make a lot of money and didn't care who he hurt to make that happen.
It wasn't like, he's a really bad guy. It was like the devil himself had walked in this room.
So that's just a short clip about a couple of stories I'm about to tell you. There we go. So let's start with the issue, right? So in the United States now, substance use disorder is a significant illness that you see in a wide range of people. SAMHSA is a very good resource for those who want to learn more about substance use disorder and different ways of approaching it and different ways of treating it. We can have a discussion of what came first, the chicken or the egg, with respect to the terms of mental illness and substance use disorder. I will submit to you that in my view, and I'm not a doctor, I didn't even play one on TV, but my experience tells me that substance use disorder, drug addicts are born and made. That's not necessarily true for other forms of mental illnesses. For example, bipolar disorder, you're born with the biochemistry of that. Substance use disorder, you see most people who have been diagnosed with substance use disorder, of course, have another diagnosis that underlines it. It can be depression. It could be on the scale of more difficult diagnoses to live with, treat with, and treat for, and go on with. But it is a significant issue in the United States today. The cost of untreated substance abuse is pretty significant. There's, I think everyone on this seminar certainly knows of these things, criminal justice, healthcare costs, other forms of disability and other forms of disability and the like. So it isn't going away, and just say no doesn't work. It never did. So what is addiction, substance use disorder, however you want to define it? So it's the same thing as other types of physiological and or mental illnesses. So it's diagnosed in the same manner. It's an interruption of functions, and it's having the inability to function when you're in the midst of it. So I like this slide a lot because it compares other types of disorders to addiction, substance abuse. So, folks who have diabetes, right? They have a disorder of their pancreas, and it does certain things anatomically and physiologically when you have the diagnosis. It's the same thing if you are a drug addict, right? There are certain physiological changes that are in response to the use of a drug or alcohol. It doesn't matter. I mean, a drug is a drug is a drug. So alcohol, I don't care if it's alcohol, opiates, whatever. It's the same thing. It's the same mechanism. And once you start to develop this, there are absolutely physiological responses to the ingestion and continued use of any kind of mind-altering substance. So the other thing you hear if you're in the world of substance use disorder is that, back to the just say no thing. The amount of people who require additional treatment or have a recurrence, or as it's known, a relapse of their substance use disorder or their addiction. There are other chronic illnesses that have the same sort of comparisons. When you look at type 1 diabetes, used to be called juvenile diabetes. Hypertension is a really good one, as is asthma. Some of these things, in particular asthma, there is a certain amount of user stuff, abusing parts. So people who have asthma probably shouldn't smoke, right? But we see that they get asthma attacks in response to smoking cigarettes. And you might say, well, maybe you should stop smoking cigarettes. But for some people, it's not that easy. So again, this is just a picture of the brain, but it's a complex illness, addiction. And it's from a lot of different things, but what's important is how to treat it now. So, for example, would we imply that because you have, you're an addict, that your poor lifestyle choices is what caused the disease, right? We do this with addicts. We don't really do this with other chronic illnesses. And would we insist that you go to certain types of classes or we won't treat you? right? That doesn't really happen with diabetics or asthmatics. It does happen with people with substance use disorder. And would we just discharge patients from the hospital because they kept eating poorly, they didn't lose weight, they didn't do what you told them to do? Usually not. We try other avenues of approaching that particular patient. So the patient who presents to the emergency room with a blood sugar of 800, and for those who don't know this, normal blood sugar is under 100. But they keep coming back and back and back because they keep eating the 3 pounds of M&Ms, right? You wouldn't bar the door and say, get out of here. You would try other interventions. Maybe they need a psychiatric consult. Maybe they need a social worker consult, but they may need other ways to help them. We do not treat substance abuse disorder this way. So where can you find information about how the diagnosis of substance use disorder is made? There are 2 main sources. One is the DSM-5, and contained in that, there's a list of the symptoms that, have to be assessed as to whether somebody meets the diagnostic criteria. And these are not like, you all probably have seen this in real life, but in everyday working with survivors and other folks, but this is what it is. And it takes over time more and more to do less and less. So the increasing tolerance levels of number 7 is really where people can really get themselves into more difficulties medically, as well as in other aspects, because they have to keep taking the drugs at higher amounts to attempt to get to that place where they feel comfortable. The other source is the American Society of Addiction Medicine. So there are a number of, and this is a newer organization, there are a number of physicians who are now board certified in addiction medicine. The ASAM criteria is also sort of the working Bible, if you will, of substance abuse treatment. And we'll get to a little bit about that later. But this is how they define addiction. It's a primary chronic disease of the brain. That's the important part of it. It's a brain disease. And again, they're using sort of the same language from the DSM-5, right? That you have a number of dysfunctions in a lot of the things that we do every day. So biological, psychological, social, and spiritual. And the individual pathology, right, is that moment of loss of control, right? That the drive to use overwhelms your brain, and that becomes the only thing you can see. So the characteristics of substance use disorder are all these C's. So craving, which we just talked about, compulsion, that using against your own will, if you will, loss of control, continued use despite consequences. This is really, really important, because when you speak to people who are addicts, have substance use disorder, they will describe that there's a part of them that knows that every time they are having some trouble, there's usually alcohol and drugs, involved, and it may not happen every time. Right, so they can have a drink or a drug and nothing terrible happens, but they can't predict when that's going to be that something, they drive a car, when they're impaired, or they do something else that creates a risk to other people, including themselves. And then the chronic maladaptive behavior. So things that they're lying to your family and loved ones, maybe, doing some petty crimes to get money to buy the stuff that you're trying to get, or other types of behavior that you see in relation to substance use disorder. And this is a saying that for those of us who are sober, we talk about this, but this describes the phenomena of craving. And it's kind of a silly saying, but it really makes sense. The first drug or drink gets you drunk, which kind of doesn't make sense, right? Like you only have one drink, but that sets up the physiological craving phenomena that we're talking about it, which is why, you know, abstinence is certainly a path to not getting back in that cycle, but it's not the only way, but that's certainly where that comes from. So just to show you a couple of scans. So this is from the director of the National Institute of Drug Abuse, but these are two scans. There's the healthy brain is on one side and the drug user's brain is on the other side. And you can definitely see the color change. And this has to do with uptake and where there's sort of actually damage in the brain and when there isn't. And I think the next slide is a little better demonstration. Okay, so this is a picture of a healthy brain and what it's supposed to look like. This is from somebody who was a methamphetamine abuser, and this is about 1 month after they are without abusing methamphetamine. Then the next picture is 14 months later, and the brain looks pretty much back to normal. Why is that important? Because it has a lot to do with the length of stay and what one can expect from appropriate treatment and long-term recovery and sobriety. That there is hope, that this is not a hopeless condition, that of which there is no ability to have sustained remission. And again, another resource to look at if you are interested in, you know, these types of civil claims and where the standards of care would come from is the ASAM criteria. And I mean, you can, a lot of stuff you can Google and get, you know, I have a copy of the book, but there's other ways to do this. And it defines within that textbook the different levels of care plus other types of assessments that all treatment providers should be following in order to do that. And we're going to get to treatment providers specifically in a few minutes. And again, the purpose of these textbooks, and then there's lots of forms, is to help a person who's being assessed and the assessors, if you will, develop individualized treatment plans instead of just because of the way of the program is set up. So what am I saying? So as a former nurse and a lawyer who's been looking at medical records for a very long time, one of the shocking things to me when I first really started handling these cases and getting the records was how much they were exactly alike. So specifically, I could line up 10 charts from 10 different patients and they would say the exact same things. This is not what the purpose of records and forms are, right? That it's important that people are treated at the appropriate level of care for their specific needs. And no group needs that more than sexual abuse, sexual assault survivors. So I won't go through all 6 of the dimensions. I'm just going to show you what they are. This is a better chart. So the assessment criteria, which was based on the thing I just whipped through, right, is how to place patients in the appropriate level of care. So the idea behind substance abuse treatment generally, which is not a bad thing, is you're supposed to, you know, it's not one size fits all, and not all patients need the exact same thing, depending on their presentation. And we'll talk about the Florida model in a few minutes, which has kind of gone, it's like a virus throughout the country. But specifically, they being the treatment providers, are supposed to determine whether you initially, number one, what your level of intoxication and or withdrawal is. Not everybody needs to be detoxed, okay, in the formal setting of detoxification. It depends on a lot of different medical factors and sociological factors. So that's the first dimension. The second are the biomedical, meaning specifically, does this patient have other medical conditions, when other psychiatric conditions, like what is going on with this person today as they sit in my office and I do the assessment. And then of course, their behavior. Are they coming willingly? Are they being, ordered there by a court? Are they being told if you don't go, you're going to lose your family? Are they being involuntarily brought to treatment? In some states, Florida has what's called a Marchman Act, which is a process in which you apply to the probate court to get somebody involuntarily admitted for substance use disorder. It differs from where most states have an emergency hold order that will allow the police or the healthcare providers to hold somebody against their will if they are a risk to themselves or others. It's the same criteria. They have to be a risk to themselves or others, but this is specifically for substance abuse. But you need to know that if you're, what's because that brings you to number 4, their treatment acceptance and resistance, right? Like, are they willing to engage in treatment, and what kind of treatment are they willing to engage in? And then what is their relapse potential? Meaning, in the beginning, specifically of you're coming to a substance abuse treatment center, your highest risk of relapse is in the beginning of you being detoxed. So that goes back to number 1. You got to look at, where are they, that individual, in this process? And that is very important. The most important thing and the biggest problems that I have seen, and we've seen nationally, is the recovery environment issue. So, most people who haven't had experience with substance abuse treatment have an idea that, this is all an inpatient kind of world, and you stay there till you're kind of ready and then you get discharged. The majority of programs in the United States are actually intensive outpatient programs. So by definition, they're outpatient programs. And so the folks need to live somewhere. The original intent of IOPs was that, I would be in my community, I'd be home and I'd be going to a treatment, after hours, like, I worked all day and I go to the treatment facility from like 6 to 9 p.m., 5 days a week, or sometime during the day. What has evolved for a lot of different reasons is the IOP model with a recovery residence, or what one would call a sober home. And there's lots of issues with those that we will get to in a minute, but that's the basic criteria. So based on how an individual rates, if you will, within the dimensions, will determine what level of care they really need. This is not really what happens in practice, but that is the ASAM criteria. So I was talking about sober homes. So sober homes, also known as recovery residences, were developed or really started in a lot of different, they were kind of area specific. So for example, Palm Beach County, where I reside, became the recovery residence capital for a couple of reasons. One is that there were 2 pretty well-known substance abuse treatment facilities in Palm Beach County. One was a high-end place known at that time as Hanley Hazleton. And they also had a statewide recognized program that you could go to with out a determination of your ability to pay. So you could get it, once you were accepted in there, you didn't have to pay, you know, for its treatment. So it was a great program for a number of years. Out of that, people would get sober, they do well, they'd say, hey, I'm going to stay in Palm Beach County. So the recovery residence business was somewhat born here, you know, especially as it related to Hanley Hazleton, because their other location was in Minnesota. So when people would call, I need help, right? And they're in North Dakota, they'd ask them, well, do you want to go to Palm Beach County in February where it's sunny and warm, or do you want to come to Minnesota? So, you know, I think I would have come to Florida too. Anyway, so all these mom and pop houses were started, which were wonderful, right? They were safe places for people who were in recovery to sort of come back into the community and, you know, sort of get a period of time of recovery under their belts, and then either go back home or stay in South Florida, whatever their choice was. Over the years, there is now an organization called the National Alliance of Recovery Residences. Not every state has an affiliate. Florida does, FAR. And many states do, but it's not national. But it is a good place to go for information about what recovery residents should and should not be doing in terms of, you know, their operational practices. To my knowledge, there are no recovery residents. There's no licensing of recovering residences, and I don't think in any state. There are certification processes. And, you know, when you get down to the meat of these types of cases, it's important to know if they're certified or credentialed in some ways, and if they're not. In and of itself, there's nothing that requires recovery residents to be certified in most jurisdictions. Florida, because we have a pretty active task force, we now have a law, and we're trying to expand it, that requires that any substance abuse treatment facility can only refer to certified recovery residences. And I think that has helped somewhat. And let me just say one more thing about recovery residences. If in terms of civil litigation, I have learned the very hard way, sort of how to investigate them, see what they have, who's involved, and that kind of thing. So that, you know, I'm happy to share all of this stuff in more detail. If you email me after the presentation, I want as many people in the country to know about this. And if that's something that has interest to you as a practicing attorney, or as somebody who wants to, you know, share possible resources with people, I really want to help, because I think that that's how things get changed. So now I'm going to try another one of these videos. Oh, this one's going to play too good.
This is not a case where a few bad apples spoil the whole bunch. This is a case where most of the apples are spoiled.
Palm Beach County State Attorney Dave Ehrenberg is talking about the drug rehab industry in South Florida, where some 400 addiction treatment centers are luring thousands of young people.
Parents send their kids down here to South Florida to get well, not to die.
With more rehabs here per capita than just about any place else in the country, Palm Beach County might well be considered the recovery capital of America. And while there are some good facilities, sadly, scenes like this are playing out every day here. This is body cam video of police responding to a drug overdose. 24-year-old Allison Flory died in the very place she was supposed to be getting help for her addiction. She'd come here for drug treatment at a facility called Reflections. Did you get a phone call from the people at Reflections?
No.
No one called you?
No one ever called me to let me know.
To this day?
No.
I mean, what kind of people? run a facility where a young woman dies and they never call her parents?
No, there's no condolences, there's nothing.
Allison had gotten caught up in the Florida Shuffle, a criminal scheme born of the opioid crisis. It's making some people very rich and putting others at risk. Like millions of young people in America, Allison became addicted to opioids. Her parents say it started with pain pills in high school, and by her early 20s, she was in serious trouble. She tried rehab near her hometown outside Chicago, but relapsed. Her parents were desperate. So Florida, why Florida?
The facilities down there that we heard about were very good.
It was beautiful.
It is beautiful, and it seemed like a good fit for her.
And you felt at this time hopeful?
I felt hopeful more than I'd ever felt ever.
The rehab center provided a free plane ticket, and Allison was off to South Florida, where a new model for rehab is creating a crisis.
So I had the privilege of representing the Flories in their case. It's recently resolved. What's important to know is part of Allison's story is that at times, at reflections, she was part of the deal, if you will, was that she would work in a strip club owned and operated behind the scenes by Mr. Chapman. Mr. Chapman actually wasn't one who should be owning a substance abuse treatment facility because he was already a convicted felon. He is now, fortunately, doing 27 years in a federal prison. I mean, the first video you saw was also related to those cases involving the Reflections Treatment Center. The young women and some men, you saw one of the moms of a young man in the first clip. Her son was also given drugs to prostitute himself, as well as the other clients that I have represented. So obviously the worst of the worst. And he's serving 27 years in prison, as are, I think, all of the medical directors over a period of time, except one whose case is still on appeal. A number of other people that were involved in this, as we call it, the Florida Shuffle, were also convicted. So I'm just going to give you the basic scheme. The scheme is the same in every state. Okay, it just depends on how it shows itself. So what happens and you heard it, all of these kids, and I call them kids, but they're young adults, primarily under 26, so they're covered under mom or dad's health insurance at the time, were convinced, their families were convinced that they had to come to Florida, that Florida was the only place. And the kids, naturally, some from cold places in the country were like, hey, I'll go to Florida, it's by the beach. Now, I will tell you, some of these homes were farther away from the beach than perhaps Nebraska, but be that as it may. So the patient would get flown down here, which is a violation of the Patient Brokering Act, right? And would end up in this circle, right? They go to detox and they go to inpatient. Then they go to outpatient, and these PHP, IOP, OP are just different levels of care. Then they'd go to a sober home, then they'd be sober. The problem with that, there was no real money in that. So the money comes from this, the kickbacks from the marketers to the detox to the labs. So for example, in the Flory case, and she had the billing for outpatient services was $750,000. At least half of that was in urine drug screens. And so there were kickbacks with the labs and all the other stuff, in addition to the human trafficking and the like. So there are other states that have had these problems, California, Arizona, any of the sunshine states, if you will, that have a higher amount of substance abuse treatment centers, because that's how they market them, right? They market them to say, hey, you can get help and be on a sunny beach in California or South Florida or in the mountains in Arizona or what have you. Oh, I forgot the little dollar signs. You get the idea. There is absolutely no money in sobriety. Right? Once they go through the system and their people are stable and sober, the cycle doesn't work anymore. So let's turn to survivors of sexual assault. Okay. This study shows that survivors of sexual assault are more likely to develop alcohol or drug problems, right, as what this study shows. That doesn't shock me in any way, shape, or form, because most people that have substance use disorder will tell you that there was a lot of trauma in their lives, and that they were drinking or drugging at something just to feel normal, just to feel a part of, just to feel the relief of the stress of whatever they're feeling, to relieve some of the symptoms of PTSD and the like. So it's not at all surprising to me that there's a large group of folks who are survivors who end up at substance abuse treatment. So I'm going to jump quickly to go through a case example. And I hope this is helpful. So, I made up the name of the place, Coast Recovery Clients' Rights Statement, but I will tell you most treatment centers, substance abuse treatment centers on their websites have resident rights or, client, we're going to give you this, we promise to do this, that kind of stuff. And that is actually pretty informative, because I've certainly used these in depositions of defendants who work for a treatment facility. So this is a really good source of information. And I will tell you that unfortunately, this isn't what happens every time for somebody who's in a treatment center. This is just more, medical research regarding what I just said. So this is a resource you could go to if you want to learn more specifically about substance use disorder in men and women who have had childhood or even adult sexual assault abuse experiences. So let's talk about what happens. Let's talk about what I've seen happen previously. In substance abuse treatment, which is not so true in other medical treatments, right? We have an idea that we should be, that AA, or the principles of a 12-step program, is how you apply treatment. As a proud member of Alcoholics Anonymous, I know they say anonymous, but I get to disclose my own place, right? It is a completely different relationship. So the relationship I have with other women in the room, right? The rooms that we call it, the rooms, right? Is one of peer, if you will, right? Even if I am the person who's going to take somebody through the book and the steps and all that kind of stuff, right? They're not paying me. And there is no expectation that I am a therapist or a physician. I am just another alcoholic, another bozo on the bus. And I share my experience with them. So maybe the best way to use an example here is, if I am a survivor of cancer, right? And I went through a certain, bunch of treatment, and I come through the other side. I absolutely have experience, strength, hope to help another person who's going through a similar situation. But it doesn't make me an oncologist. It doesn't make me, a doctor. And in this field, you will see, and this is no slam against licensed clinical social workers, licensed mental health clinicians, but you will see that there's not a lot of supervision and cross communication. If you look at any of the organizational charts for some of these places, you'll see they're like different silos, like medical, psychiatric is in one silo, and then clinical services are in another silo. And they may be like together, but they're not really adequately communicating. And what I think happens, but this is my opinion, what happens as a result of that is that there are well-meaning people that may enter it, but they're not prepared really to deal with patients who have really, in some cases, very complicated social psychiatric histories. So, I think all of you probably know that having sex with clients or patients is considered a no-no. And why? Because it's so damaging to the patient or the client. And, most states and almost every organization, whether it's psychiatrists, social workers, all of the helping professions have a prohibition about not having sex or dual relationships with your client's patients. And that's a good place to go for really to have an understanding of that, is those kinds of requirements. This comes from Florida's rule concerning the certification board, which applies to certified addiction professionals who aren't necessarily, they don't even have to have gone to college. And I'm not saying that's a bad thing in and of itself, but they lack training and oftentimes they lack supervision. So this brings me to, what they're supposed to do and not do, and I'll whip through that one right here. These are the 12 steps. So what happens? What's the case? The case is I represent a woman who is usually, younger, but not necessarily a kid, who has a history of child sexual abuse. They've been drinking and drugging. Their lives are becoming unraveled around them, and somebody intervenes, a spouse, a family member, whoever, or maybe it's a court intervention, and they're told you better go to treatment, and you want to go to treatment. So because you recognize that things are, out of control. So you show up at, some pretty nice place in South Florida, Arizona, California, or in your own town, and you are detoxing, you are as vulnerable as you can be, and you don't know what to do with yourself, right? Because you're having these physical manifestations, you're feeling all sorts of emotions, shame, how did I get here? I should stop drinking, I should have just said no, all of that kind of stuff comes up. And you may have a therapist, and the therapist may be doing everything appropriately, right? And then one of the techs, who likely a former patient of the same facility, who's in a 12-step program, starts chatting with you, starts chatting you up and saying all the things you want to hear, like, hey, it's really hard, I've been there too. And one thing escalates to the next thing. And the next thing, we have the tech sexually abusing his client patient. So what's the first thing that happens after that? Sometimes these folks leave treatment and never tell anybody because they're embarrassed and ashamed and somehow think it's their fault. The second group may report this to the facility itself, and they are immediately not believed. And they are immediately told that, what, and this is 12-step language, what was your part in it, right? That's step 4 and 5, right? That's not the time for this. And they take no action. And what are they supposed to do? Well, they damn well should investigate this, right? They may have a predator in their midst. They need to remove that predator, right, from that situation. They also need to offer services for the poor individual who's been victimized trying to get help. And that is the essence of these cases. It happens in all levels, right? And their alcoholism, their drug abuse, whatever their substance abuse history is used against them, right? Because they're so, well, you're a drug addict. You know, you got there, it's your fault to begin with. Or can we believe you because you're a drug addict? And on and on. Given the time, I'm going to stop talking and see if there's any other questions, although I promise you I could go on. I'm going to show you my, these are the resources you can go to, which you can have in my PowerPoint, it's fine. That might be of help. And I hope that everyone has a bit of understanding about this. And again, I am really delighted to keep talking about this to anybody who wants to hear me. So
Thank
Richard, I don't
you.
know if there's questions in the.
Yes.
Okay.
Yes. Thank you, Susan. So we do have quite a few questions. We'll try to get through as many of these as possible. We are getting a lot of questions about a PowerPoint or a recording of the webinar. There will be a recording made available on our NCVC YouTube channel. We will also send that out via email in the next few days following this webinar. So just want to answer that first because we're getting a lot of questions about that. Let's see. All right, so first question is, you mentioned it's a violation for something or someone to fly a patient to another state. I thought people going to an out-of-state rehab was common if you have the money. So I'm guessing they're trying to understand a little bit more about the legality of flying a patient out of state.
Sure. It's not the flying out of state that's the issue. It's who paid for it. So, I mean, part of in Florida and in other states, the Patient Brokering Act, right, which is very similar to sort of the anti-referral, the Stark Act in the medical practices. You're not supposed to pay for their treatment or how to get to their treatment. So one of the other common problems, so the typical scheme is they pay for your airline ticket, right? And then they give you things instead of paying rent because the housing is not part of the treatment according to insurance. And it gets complicated, but the long and the short of it is like, you're not supposed to give them things in lieu of a proper appropriate treatment. I don't know how else to say that, but it's not in and of itself. If my family decided to pay for a ticket for me to come to Florida for treatment, that's perfectly fine. It's if the treatment facility pays for it, that's an issue.
Perfect. All right. Our next question. It's more of a statement, so maybe just your feedback on this, Susan. One of our participants stated that they find that the ASAM assessments to be a huge barrier for those trying to get into treatment. They continue on to say they can be triggering, re-traumatizing, and way too long for someone to sit through. And they went on to say that it needs to be reformed, shortened, and restructured. So I guess maybe like your feedback on that, Susan.
Sure. I mean, I didn't write the criteria, right? The ASAM did, the American Society of Addiction Medicine. I will say to you, after being through the forms and taking depositions about people who are doing the form, that there is a lot of value to it. I understand there are some very triggering events there, but that's their job, for God's sake, is to, address the patients where they're at, not just go through this like a checklist, a DMV, right? They're supposed to be interacting with their individuals. I mean, one of the most astonishing things to me, because of the way they have electronic health records, is, right, they're timed. So every damn chart I've ever seen has at least 50 pages of consents, right? in addition to the ASAM criteria. So this poor individual who may be shaking is going through probably 75 pages of forms. And I'm like, first of all, I don't know about any of you, but I think that if you're impaired when you present, you probably should not be signing legal documents, right? And it's perfectly appropriate to do the assessment gently and slowly. And I will tell you, I have talked to many a person doing those assessments, and that isn't what happened. So I do agree that something needs to happen. I'm just not sure that the structure of it needs to be changed.
Thank you, Susan. We do have a couple of other questions about receiving your email, Susan. So in our follow-up email with the webinar recording, we will make sure that we include Susan's contact information as well. Let's see. Do you think that detox facilities should offer forensic exams if a client would like one after an assault?
No, I think that a exam needs to be done in a facility that's set up to do these properly, right? I mean, in a substance abuse treatment center, who's going to do that? They have maybe a psychiatrist or a physician around, maybe not. So no, they need to be referred to somebody appropriate. Maybe it's a gynecologist, maybe it's the local emergency department that has a facility for this. It needs to be taken seriously and done as if, you know, this individual presented to a hospital and said, I've just been the victim of a sexual assault.
Thank you, Susan. We have another participant who is asking if you've ever spoken with a sexual assault victim who is afraid to report due to collateral punishment for drug abuse.
Absolutely. I mean, many of my clients are in that. That's why they don't sometimes say anything right away. So I had a client who went to detox and treatment somewhat voluntarily because she had been arrested for DUI. And she wanted to be there. She was sexually assaulted by one of the owner's sons someday I'll tell this story. It's unbelievable. So I have to tell a story. He buys everybody booze with the treatment center's credit card and then gives it to her before he sexual. Anyway, long story short, she did not report this right away because she didn't want to get in trouble and then have a problem with her criminal case pending. So it just went from bad to worse, that situation. I mean, eventually she told, and eventually the DUI worked out, and eventually we settled the case. But absolutely, that's why she wasn't telling anybody.
All right, so we are going to move on to one last question.
Okay.
Let's see. Is an outpatient treatment provider allowed to provide subway cards or bus tokens to and from the treatment program? And I'm guessing they're asking this in terms of, legality. Yeah.
It really depends on the program. Okay, so it depends on who set up the program, who's paying for the program. So specifically, if they are private paying facilities, it's usually not okay. There are certainly programs that are funded with, state funds or local funds, which is supposed to be serving as particularly population, indigent clients who may get those services in addition to the substance abuse treatment services, and that may be perfectly fine.
Awesome. All right, so that is all the questions that we do have time for today. We will be following up, as I stated earlier, with a recording of this webinar, as well as Susan's contact information. For those who have someone at NCVBA's contact information, or if you have my contact information, please feel free to reach out to me if you would like to get connected with Susan. I promise you she is always just delightful to have a conversation with. So we can definitely make that happen. So from the NCVBA and NCVC students, thank you so much for this webinar today. You can see by the chat room and the comments that our participants really enjoyed it. So thank you again, and thank you for everyone for joining us today.
Thank you. And please don't hesitate to reach out to me by email. I'm happy to talk to anybody. I think it's, it's something I want to do in my old age. So thanks, everybody. I'm glad to have been of help.